Hello, on behalf of CME Outfitters, I'd like to welcome and thank you for joining us for the virtual CME symposium entitled Risk for Opioid Overdose, Identifying At-Risk Patients in Your Practice, Hidden in Plain Sight. I'm Mark Gold. I'm a career addiction scientist. I've worked since 1972 in translational addiction neurobiology from the time of the invention of the use of clonidine and alpha-2 agonists as surrogates for opioids to the present day. I'm won ASAM's Lifetime Achievement Award, a number of other awards, and while I had a 25-year career at the University of Florida College of Medicine as a distinguished professor and chairman most recently, I'm teaching and doing some research at Washington University in St. Louis as an adjunct professor right now. I'm joined today by my friend, Stephen Stanos, and Stephen is the medical director of Swedish Health System, Pain Medicine, and Related Services in beautiful Seattle, Washington. He's a past president of the American Academy of Pain Medicine and an overall great person. Let's start by thinking about our learning objectives. Learning objective 1 to begin with is recognizing the distinct patient profiles of individuals at risk for opioid overdose. Stephen, sometimes we fall victim to stereotypes, especially stereotypes of people who we think might be at risk for overdose, or might have a substance use disorder, or might misuse opioids. But in many ways, if we take the population of at risk for opioid overdose, there are really 2 distinct populations, aren't there?
Yeah, I think it's good, Mark, and thanks for having me. And yeah, there are 2, I think, distinct groups. There's the individuals with opioid use disorder, and then those individuals with chronic pain treated with high-dose opioids or co-prescribing or co-occurring benzodiazepines. I think it's important too, maybe that second group, it may not just be the high-dose patients, but I think of the patients with, in my chronic pain clinic, patients with comorbid psychiatric problems that may also be at risk for suicide, which many times can be attempted with an overdose.
This is really very good and important, and we'll get back to this because we recently finished a comprehensive study of these 2 populations. This is aside from the fires and pandemic, as if we needed enough, we've had a big crisis in my field, addiction medicine, in that COVID-19 has been a source of stress, sleep disorders, and relapse in people with stable opioid use disorders, in people with stable substance use disorders. So slips and relapses have occurred throughout the United States. But in addition, general hospitals and academic medical centers have refocused their efforts on COVID emergencies, COVID ICUs, COVID treatment, and in doing so, have changed the whole access that took decades really to develop for opioid use disorder patients to access the health system. So I think it's really put a lot of pressure on us.
Yeah, I agree, and I've seen it too in our pain program. We also have a full-time addiction specialist, and I think there's a good overlap between chronic pain patients as well as patients with opioid use disorder with how COVID has impacted them. I think we're seeing an increase in alcohol use. In some cases, some of our patients are taking more pain medicines than they should with all the stress and other factors that are going on in their lives, even patients that are just being treated for chronic pain. And I think what my colleague that I work with that sees a lot of our patients with chronic pain and opioid use disorder, they're out of their normal environment. Maybe they're at home instead of being at work, and in the past work kind of forced them to maybe be more compliant with their recovery. Now there's less kind of oversight in what they're doing. They may start drinking again. So I think it's just separate from all the stress and the other factors related to COVID itself, just the environment has changed. And so we're seeing it both with patients with chronic pain and even our patients with opioid use disorder that may have been stable in the past are really struggling. And on the other side, I've been very impressed with some patients actually doing well. I had some patients that completed a rehabilitation program and really did well learning skills on how to manage their pain and stress. And with COVID, they were able to respond like that with good tools. So it makes me appreciate, the behavioral health interventions that these people need. And when they lose that, it can really negatively impact them. Or on the other side, if they're able to use those tools and have that access, it can really help. And I'll just actually include, Mark, in our hospital, we have an integrated behavioral health. They switched to doing, all virtual behavioral health visits. And so we're at least able to provide virtual health through our psychologists and our counselors to help support these patients. But there's just not enough of those types of counselors and psychologists to go around. And so there is this huge need. And, even if COVID recovers, there's still going to be the financial hardships and everything else that are also going to be that kind of ongoing trigger for people that are in recovery or patients that are struggling.
But we're trying to make the best out of it, recognizing right now that this has been the greatest cause of slips and relapses, and sadly, opioid overdoses have increased during the COVID time, as reported recently by NIDA. Stephen, we did this study of the two populations at risk for opioid overdose, which would be the population of those patients with opioid use disorders, a national population of these patients, and then compared them to a national sample of patients with chronic pain who are being treated with high doses of opioids. When you looked at this NAPOP, naloxone awareness and perceptions in opioid populations study and the data, did anything like strike you as particularly relevant for pain docs?
Yeah, well, what struck me, if you see here on the left in red, when they were asked, is your opioid medication for chronic pain associated with risk for overdose? Close to 58% were aware of that. I think there's been a lot of education for the last 10 years about the risk with any patient. When we put them on opioids, we go over the consent and what the risks are. But it's interesting that on the other side, when they're asked, when you're using opioids, how concerned are you about overdosing? The patient themselves, even the pain patients, were really not concerned. I mean, 60% in that survey were not concerned at all, versus the opioid use disorder patients, it was about 30%. So I do think it's the idea, and I get this a lot when I try to talk to patients that we're discussing giving them naloxone that are on chronic opioids. They don't realize, unless there's a number of risk factors that they can identify with, they rarely think that they're at risk for overdose. Because most patients believe they're doing things the right way. They don't consider when things are going to go south and when there's going to be problems. I have had patients that have maybe pulmonary issues that are really frail, and it may not be their actual opioid dose, but more if they have a medical problem and develop respiratory problems, they could overdose with opioids, right? And so trying to explain that to them, it starts to make a little bit of sense. But I see this a lot where a lot of our even chronic pain patients may not think that it's something that could happen to them, but they would maybe think it could happen to somebody else.
Yeah, I mean, there was actually an item where we asked chronic pain patients about this, and I was alarmed because 80% of people who had high dose of opioids for pain in their house said that no one in their house was at risk because of this. So they're not getting the message that the medicine cabinet risk is quite real.
No, you bring up a good point, and I bring up the patients that are maybe on higher doses. In the state of Washington, where I practice, we have set guidelines or guidance on when we should consider prescribing naloxone. But in general, even the patients that are on lower doses that I bring up that I want to prescribe naloxone because if you took too much and you overdosed, someone in your family could revive you. And then I bring up the point that also there's the idea that someone in your house could have an accidental exposure, whether it's a young child or a grandchild that they're taking care of. And I ask patients what they think would happen. And again, you're right. Most people don't think of those other consequences of people in the household that are at risk. Maybe a person with opioid use disorder, they may have other people in the family that are more familiar with what's happening. But again, I agree. I think a lot of times patients don't think of those bad events that could happen, even within their own home, and the medicines that they keep, unlocked in their medicine cabinet that anyone could get their hands on.
There are differences between these populations in many dimensions, but the even though I know you give people comprehensive education, it does seem that the opioid use patient population has a lot more understanding about naloxone and what an opioid overdose looks like and how to reverse it than the chronic pain population.
Yeah, and I agree, and I think it's because they're obviously may be more familiar with their own event in the past or other friends or people that they're in treatment with that have an overdose. Whereas I think our pain patients may hear about it more in the media, and so they're less likely, I think, to identify with it as much as a person that's has opioid use disorder. And I do think for people with an opioid use disorder, they're in groups, they're in behavioral health interventions, and maybe going to support groups. So I think there's a lot more discussion with their peers, whereas many of our chronic pain patients are somewhat isolated, especially with regards to understanding their conditions.
Let's go to objective number 2. The second objective is initiate discussions about overdose risk with chronic pain patients prescribed high-dose opioids. One thing that kind of became evident when we did this study and looked at the data is the source of information and guidance between OUD patients and chronic pain patients are the same. Patients with opioid use disorder get their health information from, and especially opioid competency information, from other addicts, from other users, and from counselors and recovery programs. And they don't have much access to health professionals or interventions with health professionals. The chronic pain patients seem to both trust you and rely upon you and your colleagues as a definitive source of health information and opioid competency.
Oh, yeah, I agree. And I do think if we look at the last 10 years, even before the CDC guidelines for chronic prescribing in a lot of the state initiatives, patients have been hearing the message around opioid safety and risks for a number of years. And so fortunately, I think the health system, even though there may be some gaps in various areas, have done a better job of trying to educate patients about that. So they've been hearing it. I do think they maybe not identify that it could happen to them. They do interact a lot with their pharmacist as well. And so that's been helpful. Besides what the physician says or the nurse practitioner, whoever is writing the script, they're also getting, I think, a lot more feedback from their pharmacist that can really, I think, be an area where they respect someone and they identify with that person. Many of our patients, see their pharmacist every month. And so they have probably more of an attachment in relations with them with a lot of the other people they interact with. So what I thought was interesting from this study was if you look down at the bottom, those patients on chronic opioids that have not obtained or any training regarding naloxone, it was 30%. So that tells me 70% we're getting some information. So I'm hoping that'll get smaller, but I do think even some of the public health service announcements and those things out in the media, there's been an uptick in that. So, but it's a slow process. We definitely want to see the red numbers a lot higher because people really need this.
When we do think about prescribing opioids to patients who are in pain and what their dose and exposure is, and what their relative risk is, we have to keep in mind whether they're exposed to benzos. Do they have access to benzos? Do they take benzos? Because that combination appears to be highly lethal, especially in the high doses. Do you see that in pain practice?
Yes, and I do think when we look back 4 and 5 years ago, some of the early data on overdoses and people were trying to figure out what the MED risk was and when did it become a high dose. And even though there was some controversy with that, they did show that in those higher doses over 200 morphine equivalents, depending on the study that you read, the benzodiazepine was the biggest driver of those overdoses. So it was really not just the MED of 200, but the MED of 200 with the benzodiazepine. So again, I do think those are the patients that are at highest risk, even though, like we like to say, any patient on any dose is at risk. But those high dose patients are easy to identify, and we really need to be cognizant about it. Many times the primary care providers aren't even really thinking about maybe a person that's on chronic opioids that's been stable and they've been taking a benzo at night for many years. They don't make that connection, and not really thinking about what happens if that person gets sick and has other medical issues, and then the benzodiazepine can really cause more problems, even in a tolerant patient.
Stephen, when you do think about this and add the risks together, you have the opioid risks that come with the chronic opioid use in pain patients. And then you add to that the alcohol risks. And now we add to that benzo risks, which in this study are about 50% of the patients have exposure to benzos, consistent exposure, and high dose opioids. How does that happen?
No, I agree. Well, I think, over time, patients with chronic pain, they have anxiety, they have sleep problems. Over the many years, they may be treated for pain. They might be started on those medications. We have other patients with panic disorder that also are on opioids that may be taking benzodiazepines. So, I was surprised by the number, but also kind of thinking about this, the patients that I may inherit, we see this, and this showed about 50% of patients were either on a high daily dose of opioid or a low dose, but we're on benzos as well. So again, this is, concerning, and hopefully this is where we really need to educate primary care providers that are maybe initiating this, or at least explaining the risk.
Yeah, no, that would be very important. And just paying attention to what you just said, there's different diagnoses where you'd get a benzo, there are different providers where benzos would be prescribed. And if you're prescribing opioids, you need to know who's getting benzos from everywhere and what the exposure is, and pay some attention to other CNS depressants as well. So what do you think? Can you mitigate the risk by opioid tapering, or do you do that?
Well, we do a lot of tapering, and I think there's really been a balance in the last year with regards to the CDC guideline being kind of reassessed by a number of different groups. And so with tapering, I think it's definitely has to be individualized. In our patients, the key is really getting that buy-in from the patient and why you're doing it. First, obviously assessing, is it appropriate for them to be on opioids? And, has their pain condition improved? Are there other treatments that could really help them that are maybe feeding into their opioid use, that maybe you need to address that first. So treat their depression and anxiety, and then try to decrease their opioids. Or we have patients that are struggling with their opioid use. It's not helping them any longer. So there's a number of different areas. We base our work primarily on what the HHS guidelines said, which I think are very pragmatic in how you can walk through this. In general, you can do a slow taper, which I think is probably the best way to do this. You really shouldn't be rushing unless there's medical issues that are more acute. But you can do this slowly over weeks and months. But you really need the patient's buy-in. So we've been doing a lot of tapering, as well as integrating other techniques to help patients manage their own pain problem. I think the key, though, is you really have to look at the patient, not just their morphine equivalent, but really what's happening with the patient. How's the pain affecting their function? How's it affecting their mood? Are there misuse issues? And then start to discuss with them why a taper would be appropriate. And on the other side, we have patients that opioids are not helping them, or traditional mu agonists, and converting them to buprenorphine many times can help with their pain, and that can actually help with limiting any misuse of medication. So there's a whole spectrum in how we see these patients that we consider for tapering.
As part of the patient management in a pain management setting, you do have to bring up the risks. Sometimes the patients might be offended by this. The WashU data said, interestingly enough, when the pain patients fill their naloxone prescriptions, they don't feel any stigma from the pharmacist or any pushback whatsoever, and feel fine about it. But very few of them actually do it. So it must be something that has to do with them and this conversation. How do you make this work?
Well, I, explain to them that just like we talk about other side effects, that there's a potential problem. You're taking medicine, whether it's a person that you're tapering up or a patient you've kind of taken over or inherited that's been on a stable dose. I explain that there's still risks for opioids, and I have to walk through and start with constipation, some of the more common side effects that they may actually be familiar with, because I think they need to get buy-in from you that you really want to help them. So you identify maybe issues that they can agree with you that they've had with their opioids. And then I explain that, opioids can cause overdose. And I think with all the news in society, there's a little bit better awareness of that from patients. And then explain, even if you feel like you're stable and something happened when you're sick and you develop respiratory depression, you could die from opioids. So we do have a medicine that could be available, that could be in your house or with you, that if you did overdose, someone there could help reverse that. And the medicine works to block the effects of the opioids. So it does take a significant amount of time to talk, but in our system, we have pre-printed information. The state also, Department of Health, has really good information and websites, so we can also give patients information about it. So what I've learned to do is actually give them information and say, I want you to read this. When you come back for your next visit, we'll discuss it. Because many times, I think if you just introduce it and expect them to take the prescription, you may not have as good a chance that it's going to work. So again, I think it's educating them. It may take 1 or 2 visits to get them to actually fill the prescription. And I also explain about our rules with the state with regards to why I'm doing it. And I don't feel I'm doing this because I think they're a bad person, but I think they're at risk or their family members may be at risk. And I think it's only safe to have this medication available in your house or your apartment in case something bad happened.
Yeah, I mean, that's really helpful. And I do think if more people followed that advice, we'd have a much higher fill rate. All right, let's go on to the last learning objective, co-prescribe and counsel. Could you just review the CDC guidelines on co-prescription?
Yeah, well, the CDC, from 2016 released guidelines for acute prescribing, and then there was some updates that actually went over what to do with chronic pain patients that are already on chronic opioids. But in general, you should consider co-prescribing naloxone for patients at high risk for overdose, and those include patients with a history of overdose. Because obviously, if you have a history of overdose, there's a significant increased risk for repeated overdoses. Patients with history of substance abuse. And they also looked at patients on more than 50 MME, which is actually not that high of a dose, and a co-occurring use of benzodiazepines. And so it was a general recommendation. Again, I think what's important here is those are pretty easy standards, but also looking at other psychiatric comorbidities that may put them at risk. So I like to teach our trainees and primary care providers, if you think about it, if you have a hunch that there's something going on with the patient, many times that's probably something from their psychiatric history or medical history that also puts them at risk. There's no issue with prescribing naloxone. And again, having that access in their house can be life-saving for them and even for someone else in the family that could overdose. I will say, Mark, that, the CDC guideline led to a lot of states putting together their own guideline. And so I think it's really important for prescribers to be aware of their state rules, which many times may be even more stringent with regards to when to prescribe naloxone.
That's a good lead in for naloxone prescriptions did double from 217 to 218, but still only 1 naloxone prescription is dispensed for every 69 high-dose opioid prescriptions written. And rural counties are 3 times more likely to be low dispensing versus metropolitan counties. And naloxone dispensing is 25 times greater in the highest dispensing counties versus lower dispensing counties. Just means to say that just making giving the advice or writing the prescription, we really need to do more follow-up.
No, and I think you bring up a good point too, Mark. And I think even prescribing the naloxone, really following up with the patient, did they fill the script? Where are they keeping it in their house? A lot of times they may even forgot the reason why they decided not to pick it up from the pharmacy. So we try to keep reminding our patients with subsequent follow-ups, did they follow up with the naloxone, and have that somewhat built into our workflows and our electronic medical record. Because the follow-up's super important. And again, it may take a 1 or 2 minute discussion with the patient to confirm why you really want them to pick up that medicine.
It's an opioid antagonist. It's not necessary. There's 1 dose that would work for most opioid reversals. It's not a treatment for substance use disorder. It's a reversal of an opioid overdose. If it's given and the person is opioid dependent, you can provoke withdrawal, but again, as everyone would know, that will go away since naloxone is so short acting. We tell people in overdose that if they only have 1 amp or 2, that if they should give it, reverse the patient, and call 911 because the person could have taken a longer acting opioid than the naloxone. The 3 FDA approved formulations: injectable, auto-injectable, prepackaged nasal spray. One of the take-home points in the study, and we'd like everyone to pay attention to, is just recommendations from healthcare providers make the difference. They might not make the difference to a person with an OUD, but the case for the pain patients is much more physician and pharmacist centric, in that they pay attention to us, they trust us, and they will listen to us if we're consistent and follow through. Don't you agree?
Yeah, and I do think though there's so much room. I mean, even here in this case, for the chronic pain opioid use patients, only 20% around received it from a healthcare provider, 14% from a pharmacist. So we still have a lot of work to do. I'm hopeful that there's more education in the communities about naloxone as well. But I would hope that number could flip and we could have people in the 80s and 90% that are aware of naloxone. Whether there's a decision has been made about filling it is maybe second, but we really need to do a better job of getting this in the hands of patients. But I do think there is a problem when you look at these types of data that, or other data sets where, it's still, there's so many prescriptions of opioids, even the patients that are sent home for surgery, one-time prescriptions, those patients would probably not be offered naloxone, even though in some states that's recommended. So I do think we have a huge pool of prescriptions out there, and you might have to break that down a little bit better.
So let me just summarize the SMART goals: specific, measurable, attainable, relevant, and timely. That is what I hope the audience take from the presentation that Steve and I have put together for you, and that you can make some changes in your practice that'll make it safer for everyone. Expand your index of overdose risk to patients who are taking high-dose opioids. Pay special attention to those that have co-occurring use of benzodiazepine. Pay special attention to those that are drinking alcohol, and we know they're drinking and binge drinking, that's so common in this population, all of which make it more likely that they'll have sleep and respiratory and other problems and are at high risk for opioid overdose. Educate your patients about the circumstances that may put them at risk for overdose. And remember that the bottom line is your pain patients trust you. They look to you for recommendations and guidance. If you give them guidance and follow through and co-prescribe, they're likely to fill the prescription and keep it in their bathroom or near their bed, and tell others in the household where they keep it. So what do you think, Steve?
Yeah, and I think the other part to remember too, and I think you did a great job of outlining those patients that are at high risk, but separate from morphine equivalent and the benzodiazepines, I think of the patients that have sleep apnea, other psychiatric problems, frail patients with scoliosis or pulmonary issues, they're also at increased risk for overdose. So really looking individually at those medical and psychological risk factors as well, I think you're doing a good job of comprehensively assessing your patient.
Well, I'd like to thank you again. It's a pleasure for me to join you here and do this presentation and share the new data and listen to you and all your great experience and advice in understanding the data and how to make this data relevant to practicing doctors. Let's take some questions.
This is from James H. How do you address the issue when patients are on high-dose opioids and on a benzodiazepine for a serious psychiatric diagnosis by a psychiatrist? Also, do you feel a patient that's on high-dose opioids and uses marijuana is at risk for overdose due to the sedating effects of marijuana?
So let's try the first half. The second half is a longer answer and less evidence-based. The first part is benzodiazepines are used and prescribed by psychiatrists for various primary psychiatric disorders. We know from the survey and the sampling of patients on high doses of opioids for pain that psychiatric comorbidity is common. They're common in these patients. And then we wouldn't advocate in any way removing the patient from a medication that's being prescribed for an important psychiatric problem, but we'd consider, is there an alternative to that medication? We'd call the psychiatrist, try to understand what the options are and discuss that with the patient. But the main finding in our sample and in clinical experience is just these are the highest risk patients. They're at high risk because of the dose of opioids plus the psychiatric comorbidity plus the benzodiazepines. And because they're at high risk, we have to be sure that we not only co-prescribe naloxone, but that they fill it and they know where to keep it and that their loved ones know where it is and how to use it.
Okay. All right, Dr. Stanos, and everyone's going to have to throw Dr. Stanos a bone because just before we went live, the fire alarm went off in his office, but luckily he can still be heard clearly. So Dr. Stanos.
Yeah, I hate to be so dramatic. And again, they're just testing the system here on a Sunday. No one else is in the clinic, but I will comment that I do think it's important to really look at what are behavioral health interventions they can use. I see a lot of patients on opioids and benzos prescribed by a psychiatrist that still need behavioral health with good cognitive behavioral therapy. So it may be an opportunity to reassess their management of their anxiety or why they're on the benzodiazepine, separate from communicating with that provider.
Okay. Well, we're gonna keep you busy, Dr. Stanos. This is from Talia W. I've recently taken on a clinic with patients on very high dose, greater than 100 MME opioids and concurrent use of benzodiazepines. Trying to bring them down safely with a multimodal approach, trying to get naloxone in home for the safety. Patients are saying they can't afford the naloxone. Any thoughts? Do you hear this often?
My understanding is most insurance companies cover naloxone, so I'd make sure you call the pharmacy to make sure that that's accurate. And in many states, it's actually free. So I would want to check on that to make sure. And most people have a minimal copay. I'd also explain that for me to take care of you, I think it's still appropriate for you. It's just as important of another medicine that you may have to pay some out-of-pocket expense for.
Okay.
Kind of like a background noise in Seattle all the time, Steve?
No, we have a lot of smoke, but not sirens all the time.
Dr. Gold, how about taking this one from Ingrid C? We know that naloxone helps with inadvertent overdose and can be life-saving, but do you often feel that offering naloxone to patients on high-dose opioids might be interpreted by the patient as, I can take more as I have something I can do to reverse an inadvertent overdose?
You know, this is a really good question. And in my day job as an expert and researcher in addiction, that was an initial thought that people had in the addiction side, was providing naloxone might provide people with a sense that they could test the limits and overdose and be rescued. The first thing to keep in mind is that most people do not have the capacity to rescue themselves. So that proper education of the patient and their family, helping the family understand what they need to do and what they need to be aware of is the key. But no, I don't see that as a way that the person will test the limits. Naloxone, quite simply, is life-saving. It's the #1 intervention in most of the artificial intelligence work that's been done to how to decrease the opioid overdoses and opioid overdose deaths, whether amongst the OUD population or the pain population, it does come down to naloxone.
Okay. Okay, Dr. Stanos, this is from Yazine C. I'm currently working with a sickle cell patient who is on high-dose opioids and insists on getting benzo since Vistaril does not work for his anxiety. And Oh, I'm sorry, and it just popped off. I apologize. So what do you do? This person is very uncomfortable prescribing a benzo because of this patient. What would you suggest?
Yeah, I'm sorry, I don't. It's unfortunate that a physician would ever feel or prescriber uncomfortable doing anything. So if you don't feel comfortable, you don't have to prescribe because a patient wants that. You can give your medical advice. You can refer the patient to another provider, but you should never feel that you're pressured to do anything. Obviously, this is what a good patient physician or prescriber a relationship is about, but you never should feel pressured. And really part of the treatment is going to include X, Y, and Z for me to help take care of you.
Okay.
Jan, I didn't answer the first question's part B, which was whether or not
The
I was
marijuana.
concerned about the interaction with cannabis. And this is as I said, that there's not the kind of evidence we have for benzos or the kind of evidence that we have for alcohol. What we know from our work and other work is that when people say they have a drink, many times they have binge drinking, and that binge drinking plus high doses of opioids is a great risk. Is cannabis a risk? It's listed on the list factors. We pay attention to it. And certainly, I mean, I've written about this and other people have written about this. I view a medication as something that's been approved by the FDA. And that kind of basic belief has helped me a great deal in discussing hydroxychloroquine and COVID-19. If the FDA defines what a medicine is, that's a very good place to be as a physician. And in these complex interactions, we have to say, well, do we think that cannabis is approved for use in pain? No. Is it proven safe and effective for pain? No. And there is actually recent data, and Steve might want to comment on this, that while there may be some initial effects, principally due to not being less anxious or worried, over the long term, we have more persistent use among people who have pain than we would have in the population at large.
Yeah. Hey, Dr. Stanos, we have a question, and you do a lot, I know, with monitoring patients in subsequent visits. So it appears that many patients fail to fill their naloxone prescriptions. I'm a pain psychologist in an interdisciplinary program and rarely even hear about naloxone RXs. Are there ways I can be more helpful in facilitating follow through? And that's from that's what Allison.
Yeah, it's hard. I mean, I think we've been giving videos to patients to watch, and it may just be that assignment for them when they go home. We want you to take this link and watch this video, and when you come back to your next visit, we can discuss it again. I think sometimes people are you get some pushback during your visit, but if you can kind of give them an assignment or something to think about walking out the door, and then at the next visit, you can follow up on that. But there are, on the SAMHSA website as well, other links to videos explaining the importance of naloxone. Some of those include patients talking about naloxone. I think a lot of times when a patient hears another patient's description, that actually can reinforce what you as a clinician are saying.
Okay. Dr. Gold, here is another one. Oh, actually, here's an interesting one from Stacy, just to follow up on that. We are modifying our chronic opioid agreement to state that naloxone will be co-prescribed. We're also updating our organizational pain policy in response to the FDA 72320 drug safety communications. Another interesting tip that might be able to be used.
Yeah, I mean, I think like what Steve was saying was that it's not just co-prescribing, it's following up on it. It's not just giving advice, it's following up on the advice. But keep in mind, for the pain population as compared to the opioid use disorder population, they will actually listen and pay great attention to their health provider and pharmacist, and over time will take our advice.
Yeah. It's an interesting one from Geetha and Dr. Stanos, because I bet you get patients like this all the time. Two patients ended up with me. One is an elder lady who has AFib and severe anxiety and is being treated by benzo with her behavioral health doctor. The other is a patient with PTSD. Both have naloxone, but challenging patients. Would you agree with that?
Oh, definitely. And I do think in our clinic, we have a pain psychologist and relaxation therapist. Regardless of the age, even 5 or 6 sessions with cognitive behavioral therapist for coping and anxiety management, as well as relaxation training, can help any patient. And so I do think if they see that you want to take a more active role and offer them something that's going to help them, instead of the focus always being on the drug, because the drug itself probably isn't the issue. I mean, they've been on it for so long. If you rush to try to decrease their benzo right away without giving them another type of treatment to help them, you're going to fail. And so I think you can they can be aware of what the risk is. Our plan is for you to do this over the next 2 to 3 months, seeing our psychologist, seeing our relaxation therapist, and then maybe we can decrease your medicine. But I think a lot of times, a lot of our elderly patients, we underestimate the benefits of behavioral health for them, thinking, well, they're older, yeah, they have stress, but they also can benefit from a good behavioral therapist. So.
True, that works the same way for sleep. The interventions related to sleep, behavioral therapy related to sleep work whether you're old or young, and you actually have more problems when you're older.
Yeah, and Mark, you bring up a good point. I think it was brought up, and I'm glad our alarms went off here in the building. So my stress levels have gone down too. This is just drama we wanted to add at the end of the day to keep you guys enticed on a Sunday. But I do think even sleep hygiene, I'm amazed. We do some basic lectures on sleep hygiene, and patients have been doing bad things with what time they go to bed, how much caffeine they drink, all sorts of easy things that are behavioral you can change. And if you don't approach the sleep hygiene, the best sleep medicine in the world many times isn't going to work. So again, going back to the basics, sleep hygiene concepts, what you can do. And a lot of times it's very novel to the patient. They appreciate the time that you've spent with offering something so easy. And then when you can take care of that, it takes away from just depending on just the medicine. The other part is, I think besides the benzodiazepine, we use a lot of other non-benzodiazepine medicines. We may start that initially and then start to cut back on the benzodiazepine, because I think we rush to try to start decreasing medicines, and a lot of times patients have been on this for many years, and to start doing that quickly without giving them other tools, you're really going to increase your chances of failure.
And I think this is going to be a good one, good question to end on, Dr. Stanos, and because it really speaks to co-management of patients, which I'm sure happens where you are all the time. And it's from Raul. Where I practice, I don't remember seeing any patient already on opioids that are coming to me to establish primary care having a prescription of naloxone or even know about it. This includes patients treated at pain clinics. What are some tips of working with your primary care pain and primary care to be sure that everybody knows what everybody's doing and doing the best for the patient?
Well, Raul, it's unfortunate to hear that. I'm in a state where there's been it's mandated that in our pain rules that depending on the risk of the patient, low, medium, or high risk, the patient needs discussion. So we've had a lot of primary care. What you could do as a clinician is maybe it takes time, but in your note, include in your assessment and plan what the links are for education about naloxone. A lot of times your primary care provider or referring doctor may look at your assessment and plan, and that may be tools for them. It does take a system approach. This is really hard. So maybe dealing with the leader of your primary care group in your hospital system, that also could be helpful to try to get them to understand this. Hopefully, as the rules increase across the state, most states will be mandating some type of education around naloxone. But I think it is tough on you. I'm sorry to hear this, but it may just be one patient at a time, one referring physician at a time that you're going to have to educate.
Okay, Dr. Gold, we'll give you the last word, but make it quick.
Just in OUD, what we've had to do is go to interventions and provide naloxone to the family at the time of the intervention. So we've taken even the step out of going to the pharmacy and picking it up and giving it to people during their visits. And that's been very effective. It's now the Yale model in emergency department interventions to provide naloxone and education on the spot.
Oh, thank you. Thank you, gentlemen, for joining us today. And for our participants, a reminder that CME Outfitters is certifying this activity. So Dr. Stanos, Dr. Gold, thank you very much for joining us today, and to our audience as well.
Thanks. It's great presenting with you, Mark. Thanks, Jan.
Thank you. You too. You're great.